So let's talk about forces, collapsing forces, expanding forces, right? To understand like COPD and go. So we have collapsing forces, expanding forces. So here, like we said, the lungs wants to collapse, right? Why does the lung want to collapse? Surface tension, right? Elastic recoil, right? The lung is an elastic tissue, wants to collapse. What prevents the lung from collapsing? Chest wall. Remember, the chest wall wants to spring out. So when the chest wall springs out, by pulling the wall pleural, right, it's going to indirectly also pull the lung as well and keep it open, prevent it from collapsing. And another that prevents collapse, the lung from collapsing is what is surfactant. Surfactant, right? So surfactant counteracts what? Surface tension. Chest wall will counteract the elastic recoil or elastic fiber, right, in the lung, basically. At rest, they are what? Equal. Whenever they are equal, right? Collapsing is equal to expanding forces. That's my what? FRC, right? So there's no problem. Everything is fine. When on inspiration, my expanding forces will be greater than my collapsing forces. So the lung expands through the air. On expiration, your collapsing forces will be greater than the expanding forces. So the lung collapses. Let's talk about surface tension a little bit here. Super important concept. Here, right? So let's say you're looking at the lung like this. One part of the lung has is this dilator. Right? So this one alveoli. This is the diameter, right, of one alveoli. This is the diameter of the second alveoli. This is one alveoli here. I'm getting air in, right, this way. I want to ask you guys a question. Where will this air go? Which lung, which alveoli will get, or which alveolars will get most of the air in to the lung here? Is it going to be this dilated one, the larger one, capital A? It's going to be this smaller one, small a. What do you think? A blessing. Which alveolus will get most of the air coming in here? The larger one or the smaller one?
I want to think the bigger one because
Mhm.
all the forces to open it has already been overcome. So there's less force to keep it open. So that's why the air will go there.
Thank you very much. So this one, the larger one, right, has what? Less surface tension, basically. So surface tension is what is inverse proportional to radius or diameter. A small alveolus has the highest surface tension. Think about it. Let's say water is here. Water is covering the surface, right? Which is what creates surface tension of this alveoli. Because the wall is they are far apart, right? Yeah, the force is not that great, right? The force of attraction here is not that great. They're already far apart. The force is not that great, right? Pulling the water molecules, right, towards each other. But look at this smaller one. If there's water here and the wall is this close to each other, what happened? There's greater force of attraction here, which will prevent it from expanding properly. It wants to collapse to my surface tension. So if I keep bringing air here, in here, keep bringing air in here, blah, 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 most of the air will be going here. Because these guys, there's high pressure here. It's not expanding. Once the collapse, high pressure here, that pressure will impede air from coming down this route. Most of the air, right, will go. In fact, eventually, this air can eventually collapse completely, right, and push all its air, right, even into the bigger one. This is not a good thing, right? We don't want this. Imagine if this is what happens in the lung. This is bad. The base is like this. The base of the lung is like this, right? Remember, the apex is like this. So what does that mean? It means all my alveoli in the base will collapse on expiration, and all my alveoli in the apex will be distended. They're going to be filled with all the air that comes in. Right. It's impractical. It doesn't make sense. So how do we solve this problem? Surfactant. Right? So what will surfactant do? Surfactant coats what? The surface, right? They're going to coat the surface of the alveoli and decrease what? The surface tension. I want to ask you guys a question. Which alveoli here do you think will require the most surfactant? If I want to, quantity-wise, which alveoli here do you think will require the most amount of surfactant put in the surface? The smaller one, the larger one? So will require the most amount of surfactant?
The larger one.
The smaller one. In terms of concentration, it's going to be the smaller one because the smaller one has the highest surface tension. So surfactant that will coat this, right, will be thicker here. They're going to coat the lining here, and they're going to be laid down much more thicker than the larger one. So the larger one, what happens to the larger one? As the larger one distends, right? What happens to the surface tension? They're going to thin out. And what happens to surfactant? Surfactant thins out as it distends. It's going to thin out. But for the smaller one, as it collapses more, surfactant thickens. Which makes sense because since as A becomes smaller, surface tension becomes larger. It needs what? Higher concentration of surfactant to overcome the high surface tension. But for the large A, capital A, as because the size is bigger than the small A, right? Which means the surface tension there is smaller, correct? It requires what? Less concentration. So as it has more surface area, surfactant will cover more surface area. So you're going to have thin surfactant, right? Lining it, which makes sense, which will be enough to overcome what? The lesser surface tension, right? In capital A. Yeah. So the smaller my alveoli is, which means the more energy I need to overcome what? Surface tension and open it up, the greater the surfactant I need, right? In that alveoli to coat the surface and overcome the surface tension. But if an alveoli is already distended, right, I don't need a lot of energy, right, to open it any further, right? So it doesn't require the surface tension, the surfactant will have thinned out, they're going to spread out on the surface, right? So their thickness is not as great, right, as the smaller alveoli. Yeah. This is in ARDS, right? The problem is what they don't have surfactant. So if there's no surfactant, what happens? The small airways collapse because it's difficult to open them up, right? Too much surface tension in ARDS. Yeah. And then the large airways will be filled with too much air, right? Yeah. You're gonna see atelectasis, the small airways, they not collapse. Small alveoli will collapse right, easily. And it's gonna be difficult to open them up. So what happens to the work of breathing? It takes more energy, right? To expand the lung, right? It takes more energy to expand the lung. Too much surface tension. Yeah. And they get very, very tired and stuff. So if the collapsing force is greater than the expanding force, right, that will lead to what? Yeah, restrictive lung disease. Like atelectasis, restrictive lung disease, ARDS, right? Their problem is what? Increase collapsing forces or lower expanding forces. Example, right? Surface tension will be high in what? ARDS, right? For sure. Surface tension will be elastic recoil will be increasing where pulmonary fibrosis, so that will increase collapsing forces. In ARDS, surfactant will be low, yeah, increase collapsing forces. In chest wall deformities, muscular junction diseases, right? ETC, phrenic nerve damage, diaphragmatic damage, myasthenia gravis, Lambert's eating. Think of it. Anything you can think of, right? What happens to their chest wall expansion? It's going to be decreased. Those muscles are weak. Or kyphoscoliosis, right? Pectus excavatum, there's less space, right? So less expansion, that also leads to what? Restrictive, right? Diseases. The lung cannot expand properly. Yeah. In obstructive lung diseases, different problem. Problem is what? Increased airway resistance. So air such that
One question before you move on. But increase elastic recoil. Can
okay.
you see that in like NRDS? Would there be like increased elastic recoil as well?
Yes. There's gonna be as well because remember hyaline membrane, right? So they have deposition of protein in the wall of the alveoli, which will decrease the ability of the alveoli to expand, right? So there will be more elastic recoil. Yes, decrease compliance. Yeah, yeah, you're gonna see that as well. Yes, but primarily surface tension surfactant issue for them, but combined with low compliance, so there'll be increased elastic recoil, less, what's the opposite of elasticity? Compliance, right? Yeah, less compliance, increased elasticity, yeah, elastic recoil, yeah. Yes, you can see that. I know when we get to pathology, you're going to see what we call, when we talk about restrictive lung disease, right? We're going to divide them further into what? Into parenchymal and non-parenchymal, right? So basically, you see these guys. These guys are properties of the lung itself. Surfactant, surface tension, acid chloride, they're properties of the lung. But chest wall is not, right? Chest wall, respiratory muscles, right? They are extraparenchymal. They're not properties of the lung. They're outside the lung. So yeah, so parenchymal and extraparenchymal. So a patient with a parenchymal restrictive lung disease, they're also going to have problem with what? With gas exchange, because the lung parenchymal cannot exchange oxygen and CO2. Patients with restrictive lung disease due to chest wall pathology, they won't have problem with gas exchange. Diffusion, sorry, they don't have problem with gas exchange, but they don't have problem with gas diffusion, sorry, to be specific, diffusion of gases. So if I check the diffusion of gases in extraparenchymal, it's going to be normal, right? Like the one we call DLCO, diffusion capacity of carbon monoxide is going to be normal because it's the chest wall, not the lung. But if it's ARDS, restrictive lung disease, pulmonary fibrosis, and co, yeah, surfactant issues, surface tension, those will affect what? The diffusion barrier in the lung. So you're going to see what? Low DLCO, right, as well, in those cases. Parenchymal, right? Restrictive lung disease. Yeah, in those cases. So we're going to talk about that more on that pathology. So in obstructive, it's a resistance airway issue, right? Airway resistance issue. So there's air trapping. Why is there air trapping? So what happens is these people have some obstruction, right? So let's say this is the airway, exhibit A. This is the airway, and the red structure there, right, is blocking the lumen of the airway. On inspiration, sorry, on inspiration, so what happens on inspiration? On inspiration, you can see how dilated, right, the airway gets. So the airway becomes more dilated on inspiration. So although there's an obstruction, but because of negative intrathoracic pressure, right, the airways will dilate, will expand, and air enters the lung. Now, on expiration, what happens? We go back, right, to the narrow, right? The obstruction will narrow because now the airways, there's positive intrathoracic pressure, the airways will collapse, and now there's an obstruction there, right, which will basically occlude the whole lumen of the airway. And what happens to the air that comes in? The air that comes in cannot leave, but gets trapped. Gonna get trapped. So this is obstructive disease. Air comes in, can't leave. Air comes in, why? Negative intrathoracic pressure on inspiration, the airways become dilated, air comes in. On expiration, positive intrathoracic pressure, the airway collapses shut by the obstruction, and then air gets trapped, right? That will lead to what? Increased lung compliance. The lung becomes distended, it's filled with air, basically, and that's what we're going to see like COPD, asthma, bronchiectasis, right? etc. Foreign body aspiration, bronchiolitis, right? Whatever. You're going to see that. So we're going to hear all this wheezing, right? Stridor and stuff, depending if it's upper airways that are occluded by something. So super important mechanism. Now, I get why there is a airway obstruction in what? In chronic bronchitis, right? There's a mucus. Asthma, I get it, right? There's a constriction. There's a constriction. Hyper-responsive smooth muscles. Bronchiectasis, I get it as well. There's obstruction and infection and stuff. Okay. But why is there obstruction in emphysema, right? There's no, because in emphysema, there's no anatomic obstruction. That's important. It's not an anatomic obstruction like asthma, bronchoconstriction, chronic bronchitis is a mucus, right? Plug, cystic fibrosis, mucus plug, right? Right. Those ones are like anatomic obstruction. In emphysema, it's not anatomic. It is dynamic obstruction, right? Dynamic airway compression. What does that mean? So in emphysema, right, patient is losing what? They are losing radial fibers. So this is the airways. One of the things that keeps the airway open, right, during inspiration is not just what? It's not just the negative intrathoracic pressure. It's also what? Radial traction So there are elastic fibers attached to the wall of the airways that attach the airways to the wall, to the outside of the airways, right? Attaches them to the lung parenchyma. These are elastic fibers. These elastic fibers create what we call radial traction on inspiration. So when I breathe in and the lung is expanding, right, it's going to pull those elastic fibers. And as I'm pulling them, what happens to the airways? The airways, the wall of the airways will be pulled as well, almost like a tent. Yeah. So the wall of the airways will be pulled as well, and they're going to expand. The lumen becomes wider. So two things contributes to what? Airway expansion during inspiration. First will be your negative intrathoracic pressure, which makes it, we know how that comes about. Increased volume, low pressure in there. Second mechanism was radial traction. Right? The elastic fibers are pulled, they expand, right? The lumen. In emphysema, what happens in emphysema? In emphysema, there's destruction of what? Of the elastic fibers in emphysema, right? So all these elastic fibers, so this is a healthy lung, a lot of fibers, radial traction, keeping the airway open. In emphysema, what happens? Less. Some of these are gone. They're going to be destroyed by what? Elastase or trypsin. Can be destroyed. How much radial traction will I get in this patient, or will I see in this patient on inspiration? Less. So there will be less radial traction, right, in this patient on expiration. Yeah, less radial traction. So I have less elastic fibers holding the airway, right, opened, right, on expiration as well. So on expiration, this patient, once they start breathing out, and they have this word, positive intrathoracic pressure, without unopposed, right, radial traction to keep the airway open, what happens to the airways? The airways at this point where there's no radial traction, what happens? They're going to collapse. So at this point now, you're going to see what? Like collapse here, around here, right? Where there's no radial traction, there's no elastic fibers there to kind of oppose the effect of what? Of positive intrathoracic pressure, right? During expiration, going to collapse. Going to collapse. We call this dynamic airway, right? Obstruction, or dynamic airway compression in emphysema. So you don't have anatomic obstruction, right? Like asthma, bronchoconstriction, COPD, blah, 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 chronic bronchitis, cystic fibrosis, where there's like mucus plugs and stuff. In emphysema is actually what? Decreased radial traction, right? Because of loss of elastic fibers, and that will lead to what? Dynamic airway compression and expiration, right? So there's no elastic fibers to oppose the collapse of the airways, right, during expiration. You're going to see this. So air comes in on inspiration, it's going to collapse on expiration, and that will trap air, right, in the lung. So that is principle, right, of obstruction. Any questions on that before I move on to the next? Okay, look at our PFT, right? We know this already by heart, right? Yeah, so you can be giving this guy and then you interpret it, right? You're going to be giving a disease and you're going to be asked to interpret, right? Then, so we're going to see this more under pathology, but you can see that it makes sense. Oh, yes, before we move on, why would, based on this radial traction principle, right? It also explains why you won't see what? You're going to see greater airflow, right, on expiration in patients with what? With restrictive lung disease due to fibrosis. This explains why patients with pulmonary fibrosis have what? Increased airflow, right, out of the lung during expiration. Because in those people, they have what? More radial traction, right? It's like the opposite of emphysema. In emphysema, there's destruction of the elastic tissue, there's less radial traction. In pulmonary fibrosis, there's more, right? Pulmonary fibrosis, they have more collagen, more elastic fiber, more. So what happens to radial traction? Radial traction will be what? Increased. There's more radial traction. So on expiration, the airways are dilated more than you're going to see in a healthy patient. Someone that is healthy doesn't have pulmonary fibrosis, and that creates what? Faster airflow, right? Out. The rate of velocity of airflow, right, on expiration will be increased because they have wider diameter. Yeah. So Same principle.
That will be in a healthy patient.
This is some pulmonary fibrosis. Too much radial traction.
Oh, pulmonary.
Yeah, pulmonary fibrosis. They have what is pulmonary fibrosis? They're laying down collagen, right, and elastic fibers in the lung. So they're gonna have too much radial traction on the airways. So what happens to the airways on expiration? They are gonna be more dilated, right? They have more basically strings, right, pulling on their wall. They become more dilated, which means more air flows out on expiration. In a healthy person will have some radial traction, but it's not as much as this. So LD is in the middle. Pulmonary fibrosis, they have too much radial traction because of pulmonary fibrosis, which means wider diameter, more velocity. In COPD and emphysema, they have less radial traction because of destruction of elastic tissue. So what happens? There's collapse. COPD. Fibrosis, too much. LD in the middle. About enough. Yeah. So this PFT, we know, right? In and out. High yield. And you can see that it makes sense. Total lung capacity, of course, in restrictive lung disease is going to be decreased. The lung is restricted from expanding, right? There's too much collapsing forces and stuff. That's expanding forces. OLD, there's air trapping, so this is really high. Residual volume, right, low as well. High here. FEV1 is low, but actually much more low in obstructive than restrictive. The reason FEV1 and FVC are low in restrictive is not because there's airway obstruction, it's because the lung capacity is low. So if I cannot breathe in, take in a lot of air, the total amount of air I'm going to breathe out on first expiration, right, in 1 second, or total first expiration would be low as well. Yeah, but in OLD, the reason FEV1 and FVC are low is because of, even though their TLC is high, is because of what airway obstruction. That's why FEV1 and FVC is low. So the FEV1 FVC ratio, which is a marker of airway obstruction, is going to be low in OLD, but it's going to be what actually high in RLD. Like I told you, you don't have airway obstruction, right? So the flow is good. Check the ratio, FEV1 FVC ratio will be greater than 75. For OLD, it's going to be less than 75. There's actually obstruction there. Then you can further divide these two into what? Into parenchyma and non-parenchyma, right? So if I check DLCO, DLCO is looking at what? The diffusion barrier in the lung, right? The alveoli, type 1 pneumocytes, the interstitial, the blood vessel capillary wall, the diffusion barrier. So in parenchymal, RLD, you can compare that with non-parenchymal. Parenchymal means the lung itself, so surfactant issue, elastic recoil issue with surface tension, right? ARDS, RLD, interstitial fibrosis. Those guys affect the diffusion barrier, right, of the lung. So my DLC will be what? Decreased. Diffusion of gases will be decreased. In non-parenchymal, it's going to be normal. So like the chest wall pathology, those ones will not affect the lung directly, right? So diffusion capacity is fine in the lung. Diffusion barrier is okay. Also, OLD2, there's parenchymal and non-parenchymal. Parenchymal low, non-parenchymal normal. Emphysema is the only parenchymal OLD. Emphysema is the only one that's parenchymal. The other are not parenchymal. Because emphysema damages the lung tissue, right? The elastic fiber. That's why emphysema is damaging. The others are causing what? Obstruction in the airway. So the lung itself is fine. Non-parenchymal is fine. The problem is usually in the airway. But in emphysema, it is the lung parenchyma that is damaged. Elastic fiber is damaged. So the diffusion barrier is affected in emphysema. The DLC will be low. But in others, chronic bronchitis, asthma, it is right, their DLCO is going to be normal because they're affecting the airways, not the diffusion barrier, not the lung parenchyma, right, itself.